You know that feeling, just drowning in information, trying to figure out what actually matters, what the key takeaways are. Well, that's what we do here on the Deep Dive. We cut through the noise, we find those aha moments for you so you walk away really understanding something. And today we are taking that deep dive into Coccidioidomycosis, or as pretty much everyone calls it, valley fever. It's fascinating, often misunderstood, super relevant if you're in or even just visiting the American Southwest. But its reach, well, it goes further than you might think. We've got a whole stack of sources here, basics, deep dives into causes, diagnosis, treatment, humans and animals.
Yeah, and it's crucial because valley fever, it's not straightforward. It's fungal. It looks like a lot of other things. And if you misunderstand it, well, the consequences can be serious. So today, we're going beyond just what it is. We want you to grasp why it matters, get that full picture.
Okay, let's do it. So this unseen threat, what is valley fever really? And where is it hiding? First thing, not bacteria, not a virus. It's a fungus. Lives in the soil, feeds on decaying stuff, a saprophyte. And there are two main players, right? Coccidioidomycosis, that's mostly California.
Mostly California, yeah. And then Coccidioidomycosis, which is more widespread other parts of the Southwest, U.S., Mexico, even further south.
And this fungus, it does something kind of, well, sneaky. It's dimorphic.
Exactly. It has two forms. That's key to how it works.
So in the soil, it's like a mold, mycelial form, making these tiny infectious spores arthoconidia.
Correct. Those are the problem. They're just waiting in the dust.
But then if you breathe them in...
Inside a host, lungs, warm, moist, they change. They swell up into these bigger spheres. Spherules.
Okay.
And then these spherules burst open. They release loads of tiny endospores. Those endospores mature, become more spherules, rupture, and boom, the infection spreads fast inside the body.
Wow. Like a little biological invasion strategy.
It really is. And that life cycle tells you where it likes to live.
All right, the geography.
Yeah. Arid, semi-arid places, hot summers, mild winters. Think southwestern U.S., Arizona, California, especially the San Joaquin Valley, Southern California, Tehachapi area.
Nevada, New Mexico.
Nevada, New Mexico, Texas, Utah, and like I said, down into Mexico, Central and South America too.
And how do most people get it? It's the dust.
It's almost always inhalation. Those spores get airborne when dusty soil gets disturbed. Could be wind, could be construction, farming.
Hiking, off-roading.
Definitely. Even earthquakes, believe it or not, can kick up enough dust.
Okay, this is crucial, though. It doesn't spread person to person or animal to person.
Generally, no. That's a really common misconception. You get it from breathing in the spores from the environment, not from someone else who has it.
Okay, good to clarify.
Yeah.
So if it's in the soil in these areas, who's most likely bumping into it? Obviously, living there or visiting is the big one.
That's the main risk factor, yeah.
But then you think about jobs.
Yeah.
People picking, moving soil.
Exactly. Construction workers, farmers, archaeologists digging around old sites, big risk.
And just people outdoors a lot. Hikers, campers.
Anyone stirring up dust in those endemic zones.
So beyond just being there, are some people more vulnerable? More likely to get really sick from it?
Yes, absolutely. That's a critical piece. Your immune system plays a huge role. People who are immunocompromised, maybe HIV/AIDS, organ transplant recipients, people on certain medications that suppress immunity, they're at much higher risk for severe disease or disseminated disease.
Disseminated meaning it spreads outside the lungs.
Precisely. Spreads through the body. That's much more dangerous. And there's also a really important finding about certain racial and ethnic groups.
Okay.
Individuals who are Filipino, Black, American Indian, Hispanic, or Asian seem to be at higher risk for the more severe or disseminated forms. The reasons aren't fully understood, but the association is there.
That's significant.
It is. And other factors, too, being older, having diabetes, or being pregnant, particularly later in pregnancy, like the second or third trimester, these also increase the risk of worse outcomes.
Understanding all that helps us know who needs to be extra careful.
Exactly. Better protection.
So let's talk symptoms, because it sounds like it can look like, well, almost anything or nothing at all.
That's the tricky part. It's a huge spectrum. And get this, about 60%, maybe more, of people who get infected, they have no symptoms.
60%, wow.
Or maybe just really mild flu-like symptoms that go away on their own. They might never even know they had valley fever.
Okay, but for the other 40% who do get sick, what does that look like, this primary acute valley fever?
Right. Symptoms usually show up 1 to 3 weeks after you breathe in the spores, and they can last for weeks, even months. Think flu, but maybe worse. Fatigue is a big one, often really profound, lasts a long time. Fever, maybe low-grade, chills, headache.
And you mentioned something specific, desert rheumatism.
Yes, muscle and joint aches can be quite severe. Ankles, knees, hips, elbows are common spots. It's pretty characteristic when it happens.
Okay, what about breathing?
Respiratory symptoms are common too. Cough, usually dry, not much phlegm. Chest pain, sometimes sharp, especially when you breathe deep. Shortness of breath,
And rashes. You said those can be a
a
clue.
very strong clue. About 10 to 20% of symptomatic people get a rash. Erythema nodosum is one type painful. Red bumps, usually on the shins. More common in women.
Okay,
If you see that, valley fever should be high on the list. Another is erythema multiforme, looks kind of like targets.
Any of the major signs?
Yeah, weight loss can happen. And night sweats, sometimes really drenching ones.
So beyond that initial sort of clue-like phase,
Yeah.
what can happen in the lungs? You mentioned complications.
Right. In about 5 to 10% of people who get sick, it can cause more persistent lung problems. You might see nodules on a chest x-ray, coin lesions. They can stick around for years, sometimes get mistaken for cancer, leading to biopsies.
Wow.
Or the fungus can form cavities, little holes in the lungs that can lead to a chronic cough, sometimes coughing up blood. Or they can get infected with bacteria.
That sounds serious.
It can be. And a really bad complication is if a cavity ruptures. Air and pus get into the space around the lung pneumothorax. That's an emergency. Chronic pneumonia is another possibility, too.
And then there's a really scary part when it spreads. Disseminated disease.
Yes, that happens in about 1% of cases overall, but much more often in those immunocompromised groups we talked about. The infection gets into the bloodstream or lymph system and travels.
Where does it usually go?
Common sites are the skin causing abscesses, sores, nodules, often on the face or limbs. Bones and joints are another big one. Osteomyelitis, arthritis. Causes pain, swelling, trouble moving, can even affect the spine.
And the brain. You mentioned meningitis.
That's the most serious form, central nervous system involvement. Coccidioidomycosis. If it's not treated, it's almost always fatal. Symptoms are things like bad headaches, stiff neck, fever, confusion. Can cause fluid buildup in the brain, hydrocephalus.
That's terrifying.
It is. And it can spread other places too. Soft tissues, lymph nodes, liver, spleen, kidneys. It can really go almost anywhere if it disseminates.
Okay, so with all these possibilities, symptoms that look like other things, how on earth do doctors figure out it's valley fever? It sounds like detective work.
It really is. The biggest clue is suspicion, thinking about it, especially if a patient lives in or traveled to an endemic area. Or if they have pneumonia that's just not getting better with standard antibiotics, or if they have one of those telltale rashes.
So clinical picture first, then what? Lab tests.
Exactly. Lab tests are key. The most common starting point is serology blood tests looking for antibodies. There are IgM antibodies, which show up early, like 1 to 3 weeks. That points to an acute infection happening right now.
Okay.
Then there are IgG antibodies. They come up later, maybe 3 to 6 weeks, and can stick around. But the important thing here is rising IgG levels.
What does that mean?
If the IgG level keeps going up over time, it usually means the infection is active, maybe progressing or getting worse. It helps track the disease. And there's another test, the complement fixation, or CF titer. The level of that titer is really informative. A high CF titer is strongly linked to more severe disease or disseminated disease. It helps gauge how serious things are.
So blood tests are primary. What else? Can they see the fungus directly?
They can try direct microscopy, looking at samples like sputum or tissue under a microscope for those characteristic spherules. But it's not always sensitive. Fungal culture is kind of the gold standard for proof, but it takes time, days to weeks, and it's a big safety issue in the lab.
Safety issue.
Yeah, the mold form that grows in culture is highly infectious if inhaled. Labs need special BSL-3 containment to handle it safely.
Wow.
So thankfully, molecular tests like PCR are becoming more common. They're faster, very specific, and don't have the same biosafety risk as culture.
And I assume imaging helps too.
Yeah.
X-rays, CT scans.
Yeah, definitely. Chest X-ray or CT for the lungs. MRI can be helpful for looking at the brain or bones if dissemination is suspected. Biopsies too sometimes to see the spherules in tissue.
Okay, wow. Lots of tools, but it still sounds tricky. Now let's switch gears a bit. You mentioned animals. It affects them too.
It absolutely does. Many species can get it, all age groups.
And you found something really interesting in the sources about horses.
Yeah, this was fascinating. A serologic survey, so testing blood for antibodies in endemic areas, found about 4% of horses had low positive IgG titers, meaning they'd been exposed.
Okay.
But here's the kicker. All of those horses were completely asymptomatic. No signs of illness. and their positive titers just faded away on their own over 2 to 6 months.
So exposure doesn't automatically mean disease, even in animals.
It strongly suggests that, at least in horses, it really changes how you think about a positive test result sometimes. Exposure versus active infection.
But some horses do get sick.
Oh, yes. And when they do, the signs can be varied. Fever, chronic weight loss, breathing problems, abnormal blood work showing inflammation.
Like what kind of blood work changes?
Things like hyperfibrinogenemia, high white blood cell counts leukocytosis, neutrophilia, and high globulins. All markers of inflammation or infection.
Yeah.
They can also have abortions, skin lesions, even localized things like mastitis and, utter inflammation.
And how do vets diagnose it in horses? Similar to people.
Pretty similar framework, yeah. Blood work is key, looking for those inflammatory markers. Imaging helps a lot. Thoracic ultrasound might show rough lung surfaces, what they call a comet tail artifact, or consolidated lung tissue. X-rays might show that sort of diffuse miliary pattern, like little specks throughout the lungs.
And for breathing problems.
A transtracheal wash is often the go-to diagnostic. They collect fluid from the trachea to try and culture the fungus or see it microscopically.
And serology, the antibody tests.
Crucial. Just like in humans, the antibody titer level often correlates with how severe the disease is, and it helps predict the outcome, the prognosis.
Okay, so whether it's humans or animals, once you do have clinical disease,
Yeah.
what's the outlook? What's the treatment? You mentioned prognosis used to be seen as poor.
Historically, yeah, especially for disseminated disease, the outlook wasn't great. But there's some cautious optimism now. Recent experience suggests that the lung form, the primary pulmonary disease, especially if you catch it early before it spreads, might actually respond quite well to antifungal treatment. That's a positive shift.
So who gets treatment? Does everyone?
Not necessarily. If it's mild, uncomplicated lung disease in someone with a healthy immune system, sometimes just watching and waiting is enough. It often resolves on its own.
Yeah.
But there are clear reasons to treat. If the illness is really severe or debilitating, if the person has those risk factors for dissemination we talked about, if the lung disease is persisting or getting worse, and definitely any form of disease that is spread outside the lungs disseminated disease needs treatment.
And the meningitis form.
Always requires treatment, and not just short-term. Coccidioidal meningitis needs lifelong antifungal therapy to keep it suppressed.
Lifelong. Wow. Okay, so what are the treatments? What drugs do they use?
The mainstays are antifungal medications, specifically the azole class. Fluconazole is probably the most common first choice. It's taken orally, gets absorbed well, and this is really important. It gets into the brain and spinal fluid effectively. That makes it preferred for meningitis. Plus, its side effects are generally manageable.
Are there others?
Yes, itraconazole is another effective azole. It seems particularly good for bone and joint infections. The key thing with these is duration. Treatment isn't quick. We're talking months, often years.
Years.
Or lifelong, like we said, for meningitis or in some immunocompromised patients to prevent relapse.
What if the disease is really severe, life-threatening?
Then doctors might turn to amphotericin B. It's a powerful antifungal, but it can have more side effects, especially on the kidneys. They usually use newer lipid formulations now, which are a bit safer. It's given intravenously, so usually means starting treatment in the hospital, then maybe switching to an oral azole later.
Any other supportive treatments?
Sure, things like NSAIDs, non-steroidal anti-inflammatories for the pain and joint aches. Steroids are used very, very rarely and cautiously because they suppress the immune system, which can be risky with a fungal infection. And sometimes surgery is needed for specific complications, like fixing a ruptured lung cavity or dealing with severe bone damage.
And I imagine doctors monitor patients closely during all this.
Constantly. Watching symptoms, checking those antibody titers, you want to see them going down, indicating the treatment is working, follow-up imaging. And monitoring for drug side effects, which can happen with long-term therapy.
Okay, that makes sense. So treatment is complex, often long-term. What about prevention? Can you actually avoid getting it if you live there?
It's tough, really tough, because the fungus is just in the environment, but you can reduce your risk.
How?
Avoiding dust exposure is the main thing. If it's windy and dusty, maybe limit activities that stir things up. Stay inside during actual dust storms.
Air filters.
Good idea. Using air filtration systems in your home, in your car, especially high-efficiency filters.
What about working outside? Those construction workers, farmers.
Personal protective equipment, PPE. Wearing an N95 mask can make a big difference if you know you'll be in a dusty environment, digging, excavating.
Anything else on the environmental side?
Simple things sometimes. Planting grass or ground cover to hold soil down. Wetting soil before digging or disturbing it can help keep dust levels lower.
Okay. What about taking antifungal medicine before you get sick? Prophylaxis, is that a thing?
Generally, no. It's not routinely recommended for healthy people just living in an endemic area. The risks of long-term antifungal use usually outweigh the benefits. However, for certain very high-risk immunocompromised individuals moving to or living in these areas, a specialist might consider prophylactic antifungals. But that's a really complex decision, case by case.
Got it. And the big question, any vaccine?
Not yet. There's ongoing research for both humans and animals, which is hopeful. But right now, no vaccine is available for general use.
Okay, well, that brings us pretty much to the end of this deep dive. I feel like I, and hopefully you listening, are much better informed now about valley fever. It's this widespread fungus, looks like lots of things, needs specific tests, treatments are evolving, impacts people and animals. It's a lot to unpack.
It really is. And understanding these complex health issues, especially ones tied so closely to the environment and public health, it's just so important.
Absolutely.
And maybe a final thought to leave people with. As we see more development, more people moving into these traditionally endemic areas, plus climate change potentially shifting dust patterns, how are we going to need to adapt? How will our understanding and management of valley fever need to change in the coming years, the coming decades, to really protect everyone, people and animals?
That is a great question, something definitely to think about. Well, we hope you continue your own journey of discovery. Keep asking questions. Every bit of knowledge helps. Thanks so much for joining us on this deep dive.